joining in about 30 minutes. And yeah, so let's get started with a thyroidectomy. Essentially, what it means is it's just the surgical removal of all or part of the thyroid gland. So if it's the whole thyroid gland being removed, it's called a total thyroidectomy. But if it's just part of like a thyroid, then it's hemithyroidectomy. That's what it's called. And it's often performed to treat conditions such as thyroid cancers and goiters and hyperthyroidism. So goiters are essentially enlarged thyroid glands, and it usually happens because of like irregular cell growth. And hyperthyroidism is when there's an excess amount of thyroid produced, and this can cause an accelerated metabolism. And this one of the symptoms of that hyperthyroidism could be weight loss, like sudden weight loss. And thyroidectomy is one of the most common endocrine surgical procedures performed worldwide. So here I've included a obviously a diagram, and it shows how the thyroid looks in certain conditions. So this is obviously a normal thyroid, and this is when there's like an inflamed thyroid. And this is a goiter, which is essentially a enlarged thyroid, as I explained before. And so this usually happens because of irregular cell growth, and you can tell how big the goiter can get. Um, uh, and compared to like an inflamed goiter, inflamed thyroid. And this is obviously a cancerous thyroid, which you can see tumors right here. Okay, so we need to learn about the thyroid anatomy, obviously, because it's a very important structure that we have in our bodies. And so it looks like this. It is a butterfly-shaped gland in the anterior neck, just below the larynx. And it has a structure where there are two lobes, and it's connected by an isthmus. So you can see it here. It's like the middle part of the thyroid, and the blood is supplied from the superior thyroid artery. So you can see the external carotid here. So this is like the main artery that is flowing down our necks, just to the side. And then the superior thyroid artery is the ones that are like branching out and supplying blood to the thyroid. And the inferior thyroid artery is the one that is below. So it's right here. And it then, so this is coming from the thyrocervical trunk. So that's the major artery, which then branches out into the inferior thyroid artery, which provides blood to like the other side of the thyroid. Now, obviously, there are veins as well. And then other critical structures are the nerves. So we have the recurrent laryngeal nerve, which you can see in this diagram here. It's right here. And this controls vocal cord movement. And obviously, that's really important because that's how you speak. And superior laryngeal nerves is the one here. And so damaging any of these nerves could have an effect on how you speak, or even if you could speak. And the superior laryngeal nerve essentially controls the vocal pitch. Now, there are four parathyroid glands, which you can see in this diagram, and these essentially regulate calcium in the body. Then we also have the trachea and esophagus posteriorly. So posteriorly means that it's placed around that region. So you can find the trachea and esophagus around the thyroid, which is really crucial later on in the presentation when we talk about how we do the surgical procedure. Now, pathophysiology. So there are certain malignant conditions where a thyroidectomy is required, and some benign conditions where a thyroidectomy is also required. So one of the malignant conditions are papillary thyroid cancer, and this is quite common. It's one of like 80% of all thyroid cancers, and this usually happens and it's quite a slow-growing cancer with excellent prognosis. For those of you who don't know what prognosis means, it essentially means how a disease progresses. So an excellent prognosis means quite like a slow process, but if it's like a poor prognosis, then it means that it's quite poorly treatable. It's not really treatable, and it does result in death or like permanent damage to the body. Then symptoms may not be presented initially, so it is quite asymptomatic sometimes, and it can be diagnosed through imaging and biopsy, where biopsy is just where we take a sample of the thyroid and we analyze its cells and its structures and stuff to see if there is a cancer present. And some treatments are thyroidectomy and hormonal treatments, which are often required. 10 to 15% of thyroid cancer cases are follicular thyroid cancer, which develops in the follicular cells of the thyroid glands. So follicular cells are essentially cells that make up a thyroid gland, and they're responsible for producing hormones that regulates metabolism, such as thyroid. Uh, such as the hormones produced in thyroids. So thyroxine is one example. Now, it's also similar to papillary thyroid but it tends to be a little more aggressive. Medullary thyroid cancer is 3 to 5% of all cases in thyroid cancer, and it originates in the medulla, which is the inner part of the thyroid gland, and it's linked to the production of calcitonin, the calcitonin hormone by the parafollicular or also known as C cells. So calcitonin is a type of hormone that decreases, it regulates calcium levels by decreasing it. And so if what medullary thyroid cancer does is that it increases calcitonin hormone production, which then means that there is a lower calcium like level in the blood than actually required. So it kind of increases the production of calcitonin, which then leads to an over reduction of calcium in the body. So that is obviously quite dangerous because it can cause memory problems. It can also sometimes lead to seizures. It can lead to osteoporosis in the long run. It can cause teeth, damage because of calcium, because it's important for teeth. And another type of thyroid cancer where thyroidectomy is used is anaplastic thyroid cancer. And so it's like less than 2%, so it's really, really rare. But this is a very highly aggressive form of thyroid cancer, and it usually happens to individuals over 60, so the age of 60. And it's characterized by the rapid growth of the thyroid. So it forms like a huge goiter, and it also has a tendency to metastasize, which means that the cancer can spread to the other parts of the body. So that's why it's also considered dangerous. Treatments include surgery, so thyroidectomy, radiation therapy or chemotherapy, and the prognosis is generally really poor. Some benign conditions where where a thyroidectomy could be required is when you have a multinodular goiter with compressive symptoms. So multinodular essentially means that it has loads of nodes in the thyroid, and goiter obviously is where it's enlarged. And so so compressive symptoms mean that it's like super big and it's now compressing maybe some nerves, like really important nerves, as I talked about, the laryngeal nerve, or it could also be causing compression to the trachea or the esophagus. So then you have dysphagia and breathing problems. So dysphagia just means difficulty swallowing. Graves' disease is also another name given to hyperthyroidism. As I discussed, that's just excess thyroid being produced. And a thyroidectomy could be used for hyperthyroidism if it's not responding to any medical treatment. So if it's not responding to any anti-thyroid drugs, then that's when like a thyroidectomy could be used. Now, toxic adenoma is also when a thyroidectomy is considered, and that's when it produces excess hormones, and that just leads to hyperthyroidism. Now, we also have obviously the thyroid has nodules, and so if those nodules are indeterminate, so that's uh, when you get a result of Bethesda 4 or 5, that pattern suggests that there's a possibility for follicular thyroid cancer. So what Bethesda 4 or 5 means is essentially um, it's a type of scaling uh, like measurement essentially, where 4, 5, and 6 essentially mean that it's a type of it could be a type of cancer in the thyroid. So it analyzes the nodules in the thyroid and then it sees how malignant they are. So if it's like about 4, 5, or 6, then that is considered as like the thyroid is malignant. So that is when we kind of need to remove the thyroid. So just like a summary of this slide is that if there's uncontrolled cell growth, there's obviously cancer. So that's when a thyroidectomy is required. If there's an overproduction of hormone, the thyroid hormone, then obviously there's hyperthyroidism, which can cause a whole lot of issues in the body. So that is why a thyroidectomy could be used. Physical enlargement, so a goiter, that's compressing, any like really important structures such as the trachea or esophagus, that's also when it's used. And suspicious cytology, so that's when like such as the Bethesda test. Cytology essentially means a study of cells, and if there's like a suspicious type of result that we got, then we can't rule out malignancy in a sense because there could be a risk of cancer. So that's when we need to consider a thyroidectomy. Now, some indications. There are some absolute indications, relative indications as well. So absolute indications are when we do need a thyroidectomy. And so that's when there's a confirmed thyroid malignancy on biopsy. So that's obviously when you have cancer in the thyroid. So you do need to try and remove the thyroid or maybe the tumor in the thyroid. And then if there is a large goiter, which is causing compressions or dysphagia, which I discussed is difficulty swallowing, retrosternal goiter, which essentially means a goiter that is extending into chest cavity. So that could also cause compression of muscles maybe, or other structures such as esophagus and trachea. Relative indications where a thyroidectomy could be considered is Graves' disease, where it's not responding to antithyroid drugs or radioiodine. So again, if it's not responding to medical treatment, then that's when it's required. It also could depend on patient preference. Sometimes there are, women wanting pregnancy, or maybe the patient just cannot tolerate medications. So that is also when it's required. Again, Bethesda 5 or 6 shows that, you could be considering a thyroidectomy because there is chance of malignancy, like the thyroid malignancy. Compressive symptoms, I've discussed this before. Um, and patient selections. So you need the patient to be medically fit for general anesthesia, and the age range is around 20 to 70 years old, but you can perform it at any age, depending on the patient, depending on their circumstances. And preoperative optimization is crucial for like high risk patients that have like loads of other, diseases with them. So some of the preoperative assessments that are done are obviously blood tests. So they test for thyroid function. So some of the tests are TSH, free T4, and free T3. Then we also look for serum calcium and vitamin D levels just to check if there's enough calcium or vitamin D levels, and that also indicates if a thyroidectomy is needed. Then we also check for blood count, renal function, and if there are any thyroid antibodies if Graves' disease is suspected. Then we have imaging. So we ultrasound the neck, which is like a standard practice just to assess the size, the lymph nodes and the nodules, just to check the structure, the thyroid. Then CT scans or MRI scans if there's a retrosternal extension or if there's like a large goiter, just to check for maybe tumors or anything like that. Then fine needle aspiration cytology for nodules. That essentially means Batista 4 to 5. It's just that the process. Now, assessment, preoperative laryngoscopy. So that's when they just document the vocal cord function just to check if maybe the compression, if the patient presents like compressive symptoms, if it's having an effect on the vocal cord function. And then a cardiology review if the patient has cardiac disease, for example. Then we need to optimize thyroid status. So we give the patient euthyroid for Graves' disease if they have hyperthyroidism. Then we also need to do informed consent. Obviously, this is one of the medical ethics. We need to consider the risks and the benefits of thyroidectomy and whether the patient actually wants to go through with it or if they just want medications for it. And we also need a voice and swallowing baseline assessment to see if all the structures are fine or if the surgery is like absolutely needed. Then stop anticoagulants as per protocol because you don't really want to cause any blood clots while you're doing the surgery. Then the patient also needs to fast for like 6 hours plus pre-op. And as I've discussed, I've already discussed this, so I'll move on. So there are 3 types of surgical techniques that can be used. The most common one is conventional open thyroidectomy. So that's when there's a 4 to 6 centimeter transverse collar incision. So that's done like across, it's just horizontal cut. And so that shows like a direct visualization of all structures. So this is considered like a gold standard approach because it's the most used as well. More emerging types of surgical techniques include minimally invasive and also robotic assisted. So minimally invasive video assisted thyroidectomy is when there's a 1.5 to 2 centimeters incision. So that's just like a very small incision. And you need like an endoscopic assistance. And this is only done for like selected cases only because most cases require an open thyroidectomy, which is the conventional approach to thyroidectomy. Robotic assisted thyroidectomy, as you can imagine, this is not done very often. And so it's like a very remote incision. It could be done transorally or axillary. And it's quite limited in terms of availability right now because it's an emerging type of like technology. It also does have a higher cost because it's requiring a robot to do your surgery. For a total thyroidectomy, it's estimated to be around 2 to 3 hours, and for a hemothyroidectomy, it's about 1 to 2 hours. So it's not a very long surgery. Now, the procedure. So first, the patient needs to be lying down in a supine position, which means head down, just lying how you lie down in bed. And then you do a transverse skin crease. So that this is talking about how you do the conventional open thyroidectomy, by the way. So the transverse skin crease is made, like the incision is made above the sternal notch, and platysma muscle is divided. So you can see a diagram right here. I've put one here. So you can see the platysma muscle being removed, like being divided. And this muscle is like a thin sheet-like muscle located in the anterior neck, and it plays a crucial role in like facial expressions and neck movements. So yeah, and then the subplatysmal, so they're the ones that are beneath the platysmal muscle, and they're raised superiorly. So that means they're lifted upwards and also downwards because there are 2 sides to the muscle. Then you have to access the thyroid. So you can see that there are strap muscles right here, which are called sternohyphoid and sternothyroid, which are separated in midline. So you can see that the surgeon cuts it open, and the thyroid gland is then exposed, which you can see from this picture here. And so the middle thyroid vein is tied up, which a fancy word for saying that is ligated, and then it's divided. Then the mobilization of the thyroid lobe medially, so that's just it's situated in the middle. Then we have a superior pole dissection. So superior thyroid artery and vein are identified because we need to make sure that we don't, accidentally cut that. And individual vessel ligation is also, so they're closed. They're tied up because they're quite close to the gland. So that protects the external branch of the superior laryngeal nerve. Um, and the superior pole is then freed from surrounding tissue. So then you have to do a careful dissection to avoid injury to the nerve, because if you accidentally, injure the nerve, then the patient could experience difficulty speaking. Then part 2 for the procedure is where you have to identify the recurrent laryngeal nerve. And so this is like one of the most crucial steps because it runs in the esophageal groove. So then it's identified before any posterior dissection. And options include visual identification or intraoperative like nerve monitoring. So those are some techniques used to actually identify the laryngeal nerve, and it's traced from inferior to superior, so going up like this. Now, inferior pole and parathyroid preservation. So the inferior thyroid artery then branches ligated close to the thyroid. So those the thyroid arteries, they're ligated, which means tie up again, to close to the thyroid, because you are trying to take the thyroid out. You can't really be cutting the arteries because it could cause like internal bleeding and some really big problems in surgery, as you can imagine. Inferior parathyroid glands are then identified, and they're preserved with blood supply. Then Barry's ligament, so that's one of the anatomical structures in the thyroid. They're then carefully divided, and the thyroid lobe is then freed from the trachea. Now, obviously the removal, so the isthmus is divided from the trachea, then the specimen is removed if it's a hemithyroidectomy, and the process is then repeated on the opposite side of the thyroid if it's a total thyroidectomy. Then we have then the superior parathyroid glands are then preserved. Then hemostasis, and closure. So then you need to achieve hemostasis, which means you just make sure that there's no blood escaping from the. Sorry, was my mic muted? My bad. Um, so then you need to drain the placement. You need to drain, and it is quite controversial. I've read a couple articles, and there's a surgeon preference. So depending on the surgeon, they may do it or not. Then the strap muscles, as I showed you in the previous slide. So these muscles right here, they are reapproximated just to make sure that they're sitting in the right place. Then the platysma is closed, and the skin is closed with a subcuticular suture. Post-op care is just monitoring. You need to, do airway assessment, oxygen saturations, just to check if everything's, okay. And you need to also watch for the neck and neck swelling or hematoma. This is rare, but it could lead to like emergency crisis. Voice assessment within hours of surgery, so you need to make sure that no nerves were damaged again. Then serum calcium checked 4 to 6 hours post-op, just to make sure there's not a risk for hypoglycemia, because after thyroidectomy, there is a risk. So hypocalcemia essentially means lowered levels of calcium, which I discussed the effects of previously. And then you need to do like some management. Essentially, you need analgesia and early mobilization. So you just need to make sure that the patient is recovering well. Some other things that are being used nowadays in surgery, in thyroidectomy surgery, is intraoperative nerve monitoring. So this is used to detect the recurrent laryngeal nerve. Energy devices are also being used, such as ligashore and harmonic. And this is to reduce like operative time, to make sure the surgery is being done faster. Magnification loops, which is just to improve visualization. So they're worn by surgeons to make sure that they can see all the structures carefully. Complications that can arise is bleeding. It is quite rare. It can cause airway compromise, and it does require emergency return to theater just to make sure that nothing is, it can be fixed. Low calcium, it does happen. I would say quite a lot, like 20 to 30% of cases of thyroidectomy, but that's just temporary. Sometimes it is permanent, but this is more rare. And it's caused by parathyroid injury or removal or vascular compromise. And again, this leads to memory loss, tingling, muscle cramps, stiffness as well, facial muscle twitching in like response to tapping over the facial nerve. So, and also long-term causes could be osteoporosis and teeth damage if the low calcium persists. Then recurrent laryngeal nerve injury. So this could cause temporary palsy, which is about 5 to 7 cases, like 5 to 7% of cases. And this usually does recover in like 6 to 12 months, but sometimes it is permanent. And this is quite rare, and it's experienced in the hands of the patient. Uh, and hypothyroidism is expected after total thyroidectomy. So hypo meaning less thyroid being produced, and this is obviously caused by not having a thyroid or not having a part of the thyroid. And this requires long life medications. So levothyroxine is used. Hypoparathyroidism. So this requires calcium and vitamin D supplementation because, as I said before, the thyroid is also responsible for regulating calcium with calcitonin, the calcitonin hormone. And obviously, there's also wound issues. Sorry, it doesn't require calcium or vitamin D. It requires topical creams that could help as well, or maybe resuturing. Other rare complications could be nerve injury again, thyroid storm. So that means that the Graves' disease is still persisting. This usually happens like during hemothyroidectomy. Um, and yeah, so some outcomes, it does have like excellent outcomes. It's quite like it's quite a successful type of surgery. Most patients report normal quality of life post recovery as well. 90%, more than 90% of patients do have normal voices after the surgery as well. And it's quite like the scar satisfaction is also quite high due to modern techniques being used. And some alternatives to thyroidectomy is antithyroid drugs. Radioactive iodine ablation is also used, and long-term medical management. So sometimes maybe patients don't want surgery, and these are this type of things that can be used to prevent, the need for surgery. For nodules, so if there's a problem with the thyroid nodules, then active surveillance is needed. Um, Radio frequency ablation is also needed, and this is it's experimental. It's like an experimental technique for benign nodules. And ethanol ablation. So this is used for cystic nodules. And surgery is preferred if there's cancer, if there's compressive symptoms, or if patients just prefer having surgery done. New innovations that are happening in thyroidectomy surgery include intraoperative nerve monitoring. So this is quite a new technique, and it reduces nerve injury by like 50% in some studies. And it's standard in many centers, especially high-risk cases. Um, and near infrared autofluorescence is also being used. It identifies parathyroid glands intraoperatively. Um, and it reduces the need for inadvertent parathyroid removal, and it decreases hypocalcemia rates. So it decreases the amount of patients that um, have symptoms for hypocalcemia, which means again low calcium levels. Energy-based devices, as I talked about before, it reduces operative time by 20 to 30%. And again, there's less blood loss, so it's better for the patient. Scarless techniques are transoral endoscopic thyroidectomy that is being explored. Transaxillary robotic approach is also being used. And this leaves no visible neck scars, and it's obviously not really experimented much, so it's limited to small glands and select patients, so select patient cases. Enhanced recovery after surgery. So those protocols is that there is a day case, and we are like medics are using reduced opioid as well, and this does lead to faster return to normal activities, like using these innovations. Future directions are AI-assisted preoperative risk stratification, machine learning for nerve identification, and predictive models for complications. So predictive models basically means to kind of simulate what the patient's thyroid looks like, and so then the AI could be used for that. Molecular surgery is targeted therapy, reducing need for surgery in some cancers, and genetic testing, which then guides the extent of surgery needed. Telemedicine is also being explored, which means remote post-operative like monitoring, so they check the inside structures, and virtual follow-up consultations as well. Some select cases of thyroidectomy have like experimented with personalized approach. Um, so this tailors surgery extent based on molecular markers and active surveillance of low-risk cancers. And so essentially what the future direction is trying to do is moving towards a less invasive, more precise and personalized surgical care. And that's with any type of surgery. Nowadays, that's what like advancements in surgery is being focused on. Here are some references as well. And so now I just want to, so now we're going to move on to our guest speaker event, but I'm not sure if, oh yeah, she's here.
Yeah.
She's here.
Hello.
Yeah, hi.
Okay.
Hi,
I'll just
Anujin.
try and share my screen quickly.
Yeah, I'll just stop sharing.
Perfect. I'm not too sure how to share my screen. There we go. Is that working? Can we see?
Yes.
Perfect. Okay. I'm just going to start from the beginning. Okay, so hello everyone. My name is Anujin. So I'm just going to talk briefly about my background, like who I am, my application journey, and specifically about the Cambridge application system, some of the extracurriculars I've done, and like how it's helped me and what I've spoken to my friends who are medics now or have applied for medicine, what's helped them most, and just some general tips about time management, A levels, and applying for medicine because it isn't easy at all, I would say. So, for those of you who don't know me, my name's Anujin. I'm a first year medical student at Lucy Cavendish College here at the University of Cambridge. So, I'm from Nottingham. I went to Newast. I don't know if there's many other people from Newast here, but I went there for my secondary and sixth form. And I've just got some fun facts about me. So I'm a swimming teacher. I was a swimming teacher. And once I had a child poo in the pool when I was teaching a swimming lesson, which wasn't great. I started rowing here at Cambridge, and like I don't know if you guys know about the Oxford Cambridge race, the varsity boat race, which it kind of draws everyone in. So yeah, I've started doing that. I did a medical law moot, which is like a mock trial simulation thing the other day, and I didn't do very well, if I'm being honest, but it was really interesting. I found that I'm quite interested in medical law. I've bought matcha almost every day for the caffeine. It's been a lot of sleepless nights these last few weeks, but it's been good. And I did the Nijmegen marches, which is I did it through the Royal Air Force Air Cadets, so I'll speak a little bit about that later on. But during this, I basically did 40-kilometer marches for 4 days straight, which is honestly amazing. And if anyone wants to do it, I'd really recommend. All right, so I'm going to talk a little bit now about my just the application timeline in general. So in general, I don't know how much people know about the application timeline for medicine, but I would say it probably starts at the start of summer in year 12, and I think that's when you really get into it. So I mean, you could think that it starts when you're choosing your A levels, but um, in your year 12 summer, you're going to do your UCAT, hopefully. Well, yeah, most likely we're all going to do our UCAT. For me, I did my UCAT towards the end of August. I did also change the date for my UCAT at some point, but yeah, I'll talk a bit about that later. For me, quite a big part of my sixth form experience and my application in general was my role as head girl, and I applied for this during the summer of year 12 as well. And I also completed I joined the unique summer school program. And I think the deadlines might still be open. So I'd definitely recommend that. It's run by the University of Oxford. And although I didn't get my first choice, which was medicine, I got maths instead. I think it was a great opportunity. So I'd really recommend. I think it might still be open. So definitely have a look at that if you're interested in, even if you're not interested in Oxford, it's a great experience, honestly. And then it really ramps up in September in year 13. So everything sort of compounds on you at once. So you've got your UCAS deadline, which is relatively early. If you're doing medicine or applying for Oxbridge or dentistry or vet med, it will be early October. I think it's around October 16th, so it's just passed. And for me, I wrote my personal statement in September, which probably wasn't the best idea, but I think it worked out the best for me because I could spend all summer focusing on my UCAT and ensuring that my UCAT was the best it could be. And I think that the UCAT plays a vital role in your application in general. So the better your UCAT, the more opportunities you're going to have. And I think the lower you go with your UCAT, your opportunities become more limited. So I think everyone should aim to do as high and as well as they can in their UCAT. So that's why I dedicated all my summer to that and didn't really do much of my personal statement. And I started my personal statement the start of September. And I also had my September mocks at this point, which our school was using for our predicted grades. So yeah, it was a really, really stressful time. But I mean, once it was over, you move straight onto your interview prep. It's a crazy year, year 13. But so we submit our application in October. I think I did submit mine the day of the application, which was very stressful. And I think our head of year was extremely stressed that day. But we do our interviews, and you generally get interview offers from October-ish onwards. And I got my last interview offer around March, so it was really, really spread out for me. My first interview was Cambridge, so I got my first Cambridge interview around this time last year, November 17th, and my interview itself was a month later, December 16th, and I applied for Pembroke College. And then for Cambridge itself, we have a specific day where all the offers get given out, so they aren't on a rolling basis. So on the 30th of January, everyone finds out whether or not they get an offer or whether they've been rejected. But in terms of my other universities, I think I got my Edinburgh interview around New Year-ish. I think it was late December as well. And my actual interview was early January, so it was a very short turnaround. I got my Imperial interview the day after hearing my Cambridge results. So it was about February 1st, and my interview was in April. So it was really, really pushing it back. And then I think my Bristol one was also really late, and I had my Bristol interview about April time. So I would say don't be too worried if you're not hearing back from your unis, because I think they do take quite a long time. So like at that point, most of my friends had got all their offers, but I was still waiting on interviews, and I think people were waiting until it was quite late in May for KCL, King's College London interviews. So it really just depends, I think, on the university, but don't worry too much about that, I'd say. And then April to August, you've got to lock in and you've got A levels. And I got into Cambridge through the summer pool around on A level results day, well, the day after A level results day. So I'll talk a little bit more about that now. So the Cambridge application process is very, very different, I'd say, from every other university I've applied for, other than Oxford, of course. I didn't apply for Oxford. I've got some pictures here. So my college, we had our winter super formal. So there's a little picture there, and that's King's College Chapel. It's honestly a beautiful city. Please come and visit and definitely have a look. I'd recommend this to everyone. So the interview itself is very, very science based. So I had two separate interviews, and I had two interviewers, and they asked me a series of questions on scientific topics. So I remember one of them was about the kidneys, one of them was about antibiotic resistance, and it was just purely they'd give you questions about the content, and you'd have to explain your thought process, explain how you'd go from this to this, and try and explain processes. It varies from college to college. I know different people have had different styles of interviews, but mine was very much like that. And I think generally for Cambridge as a whole, it is very science based, especially for medicine. Um, the application process is very holistic, so you don't need to have the highest UCAT to be getting in. I think it varies college to college, generally. So, oh, I don't think I explained. Um, I I initially got rejected from Cambridge, and they have two systems. So they have a pooling system where you've got the winter pool, where before you get your rejection or your offer on January 30th, you have the colleges decide if they think you should be eligible, if they think that you're good enough to be a Cambridge student, they'll give your application to other colleges who might have more space, because most colleges tend to take five or six applicants. Some of the bigger ones will take 20, but that's only one college that takes 20. But the application rates vary per college. So if one college is significantly oversubscribed, they'll pass on these capable individuals to other colleges, and they'll review their application and decide whether or not they want you. Um, so I got rejected from the winter pool as well, which was quite an upsetting day for me, honestly. But I got put in the winter pool, got rejected from it, but they offered me the summer pool. So this is a process where on results day, if people have missed their offers, essentially their own version of clearing. So if people have missed their offers and they've reviewed your application, they think it's good enough, but they just didn't have enough spaces, they'll review your application again at certain colleges. And I got pulled into Lucy Cavendish College, which is where I'm at now. And at that time for me, I was debating. So I'd got my offer from Imperial, and that was going to be my firm choice university. I had a really difficult time deciding which one I was going for, because I'd spent 6 months essentially set on the idea that I was going to Imperial, and to get this sudden decision that I just wasn't expecting. It was an amazing opportunity, and I think I've definitely made the right choice for me. But yeah, that's just a bit of an overview about the pooling system. When you're applying, you apply an interview at an individual college. So I applied for Pembroke College, and I interviewed there. Or you can submit an open application, which is essentially where you're applying at your application gets sent out, and one college will just randomly get assigned to you, and you'll essentially do your interview and the whole process there. They do take a holistic view of your applications, so they tend to obviously look at your GCSE, your A levels, your UCAT, and I know people who haven't got as high UCAT, so there are people with, well, I think it's definitely changed now, but with about a 2,800, 2,700, it really varies per person. So it isn't just on your UCAT, and this is just my opinion, but I do think it weighs quite heavily on your interview. Obviously, I don't know that for sure, but I think from what I've spoken to people about, the interview is quite a big factor. Unlike other universities where it's set out like, oh, this is your UCAT's 50% and your interview is going to be 50%, they take an overall view of your application. And they interview a lot of people. So they interview 70% of a cohort generally. So the post-interview rates are typically a bit lower. So I think it's about 12 to 15, I'm guessing. But again, this will vary on the college that you're at. So a bit about the course itself. It's a very traditional style course, and I think it gets advertised as a traditional style course quite a lot. So that means that we have two separate phases or three phases. So we have our preclinical years during which we're learning about, so we in the first year, for example, we do biochemistry, anatomy, and physiology as our three main modules. However, it's not as traditional as I personally was expecting it to be. So we have a lot of clinical applications in general. So I really liked your talk earlier, Serena, because it's generally a lot about what we're doing at the moment in our clinical application. So we have applied anatomy, which is every week, and we get given a case, an anatomical case.
No.
We get given a case during which we have to explain what happened, look at radiographs, describe how we treat this, look at the patient as a whole, which is really interesting. We've been ultrasounding, so learning how to use ultrasounds, and we have a preparing for patients course, which runs throughout the 3 years. And this year, for example, we go to the GP practice, we interview patients and sort of get into the course, get into patient contact and learning how we're going to deal with that, how to question patients, etc. So it's definitely not as traditional as I thought it would be. And I personally really like this style of course. I know my friends at other medical schools have started hospital placements, but I think it's nice to have this background knowledge of knowing what you're going into prior to going straight into a hospital. But obviously, there's pros and cons. So it depends on what you'd like and what style suits you. But this kind of feels like I'm doing a degree and then I'm doing medicine, and I get to almost be a bit more involved with other people and other courses. So I'm enjoying it. And I like the clinical applications that we're doing. It's very fun. I'm presenting in applied anatomy this week, so I'm a bit nervous for that. So our terms are 8 weeks, and this means that it's a very, very intense work week, and the pace of learning is extremely fast. So I think it was very overwhelming initially, and at the moment I'm still quite overwhelmed in how much work there is. A typical day will be 5 to 6 hours. So tomorrow, for example, I've got lectures, two lectures, an hour each, and then 2 hours of dissection. And then I've got a practical for 2 hours and a supervision at the end of the day, an hour and a half. So it's a full day of working tomorrow. But again, it depends day to day. We don't have days off like other universities, especially for medicine. It's very intense. However, I think that it's a very supportive environment compared to other universities. So the whole college system means that you've got a support network within your college. You can you've got your own tutor who's there for day-to-day issues and outside non-academic issues. And we have our supervisions, which are essentially 2 to 1, 3 to 1 teaching groups, and it depends on how your supervisor likes to do it. But for anatomy, we get taught the content before we go to the DR, the dissection room, and it helps us consolidate and understand learning. For physiology, we're going through questions and concepts that we didn't fully understand or difficult topics from our lectures because of how fast-paced they are. It's really nice to consolidate it. And for biochemistry, we go through our essays and really consolidate our knowledge on top of our essays, so building on top of our essays. So as I said, we've got quite a wide range of teaching methods. So we've got our seminars, which is where we've got small groups and we're presenting, lots of practicals and our supervisions, and then the lectures and dissection rooms. And within dissection, we also do prosections. So we get to see prosections, which is also great. So I think it's the best of both worlds. I'd say there's lots of amazing extracurricular opportunities. I think the advantage of being at Cambridge is the fact that all the academics and lots of people who are really at the top high end of their research are here. So I remember one of our lecturers was introducing himself and mentioning that his partner, his research partner, has a Nobel Prize, and I just thought, I can't believe I'm here. This is insane. I'm getting taught by these people. So it's honestly amazing. And the medical society here has loads of guest speakers come in, and it's a great opportunity to network and meet new people and meet these researchers and network amongst the medical community. So I'd say it's honestly amazing. And it, not only for that, but for there's just so many societies you could join that are available to you. So I think I joined the Scrub the Stigma, which is quite an interesting society. I think they do it at other universities as well. But it's definitely a great, really like lots of medical opportunities and non-medical opportunities and just general research opportunities if that's what you're interested in. We do a lot of essay writing. Um, I think you got to be ready for typing and a lot of typing. I've got an essay due tomorrow, which is great. But um, typically, I get set 3 essays a week, but this varies per college. I get one for each main course that we're doing. But again, this varies per college. But generally, you have at least 2 to 3 essays a week. Some colleges give out 5, which I think is insane. And we do full body dissection. So this is one of the big perks. I think only us and they do it in Nottingham as well. So I think it's amazing to do full body dissection. It wasn't something that I was really thinking about when I was going into it, but I think the opportunity to have had to go through a patient and see the clinical different how different it is to what you're learning in a textbook and figuring out as you go is such a great opportunity, and you're learning more about the body and finding anatomical variations as we're going along. And we also consider it as our first patient, and it's quite an amazing opportunity. I really love our dissections. So yeah, that's a bit about Cambridge in general, Cambridge in medicine. So some extracurriculars that I've done, and I've split them up into extracurriculars and supercurriculars. Generally, I didn't get asked about any of my extracurriculars at all during my Cambridge interview. However, these were a lot more prominent in my other university interviews. So definitely it's good to have a mix of both. But I think for Oxbridge especially, it's a high focus on supercurriculars and your wider knowledge around your subject. Um, so supercurriculars are essentially just in-depth knowledge on your subject. So extra reading, extra research. So yeah, that came in really handy for my interview. But I'll talk a little bit about some extracurriculars I've done. So I was part of Air Cadets, and through this I got a lot of amazing opportunities, and I'd really recommend it to anyone who's just got a bit of free time, I guess. I started when I was quite young and I could progressed, and I did some of my highlights were instructor first aid through St John's Ambulance. I got to learn how to teach first aid and learn first aid to a relatively high level, and I acted as first aid cover on a lot of cadet events. So at our swimming competitions, cross country, I got to act as first aid cover. So it was an amazing practical experience, and I just enjoyed first aid in general. So that was another factor that led me to want to pursue medicine. I did the Nijmegen marches as before I mentioned before. I got a BTEC level 2 in leadership and teamwork. I don't know how useful that really was, but it's a nice qualification to have. And I think especially it helped develop leadership and communication skills. I was NCYC, so I was in charge of my group of cadets. So these skills in communicating and debriefing and leading the team were so valuable, and I talked about it a lot during my interviews in general. As well as that, I was a swimming teacher and I was a teaching assistant in Kumon, and it got me some money and it was nice to get the money. But I think these especially were so useful for my reflection. When I was preparing for my interviews, I looked a lot on the experience that I had had through these roles and how they'd helped me, the skills that I'd learned and how they helped me come to where I am today. And as I mentioned earlier, I was head girl, and this was a really, really big factor for me as well. So I initially wasn't really looking into doing anything with student council in year 12. I was like, oh, I don't think I have time. It looks a bit boring. But I think as I really regretted it in year 12, and I thought, why not apply in year 13? I have a lot of ideas that I'd like to change about my school. There's a lot about it that I don't like and that I want to improve. And I had a lot of friends at other sixth forms who were telling me about their experiences, and I thought I want to make this possible at my school. So I learned a lot of teamwork, working with lots of different people and organizing events on such a wide scale was difficult, but I learned a lot of skills, valuable skills from that, which again was really useful for my interviews. And I played the piano, which is just on there. Supercurriculars wise, I did the Minds Underground essay competition. Although I'd say that a lot of Oxbridge colleges run their own essay competitions. So I'd say I'd talk about this later on, but if you're not doing an EPQ, I really think you should do an essay competition. It gives you a lot of opportunity to learn these research skills and learn around the topic that you're interested in. I really enjoyed my essay and I really enjoyed researching around it. You learn how to reference, you just learn how to, the general gist of reading academic articles. So I'd really recommend that. I also did a MOOC. Wasn't that useful, but I mean, I learned from it. And I did a lot of independent wider reading on specific topics in A level that I was interested in. So it was a bit random, but I read around blood clotting a lot. And surprisingly, that was asked in my interview. So I was extremely lucky with that. He asked me how blood clots and the process of it. And so yeah, I that came in really handy. So just generally learning for me, I found on complex topics, I found it easier to understand when I went into more detail. And I felt like the A-level course didn't go into enough detail for me to understand it. So for me, I went into slightly more a bit more detail to learn the mechanisms behind what was going on. And that helped me consolidate my knowledge further. And as I mentioned, I did unique, which although I didn't do it for medicine, I did it for maths. It was still great. And not to shout out my college, but Lucy Cavendish College has a great program. So a lot of the people here had done the Lucy Cavendish program. So I think it might be closed already, but definitely have a look. And they have a summer preparation program where they support you through the UCAT process and everything like that. And my friends here have done it and they said it was really useful. So I definitely have a look at that. Which is one of the programs to consider. I didn't do any volunteering, but I think my skills and the things I learned through my jobs really helped me sort of cover that aspect. But my friends felt who did volunteering felt like that was a big factor that helped them in their application process. And it really gives you an insight into if you volunteer in healthcare, you can volunteer at the QMC if you live in Nottingham. But just volunteering gives you an insight into healthcare, what's going on behind the scenes, and you learn a lot of skills just talking to patients and getting to know people, I say. And they also have NHS cadets or St John's Ambulance cadets, which I haven't also done either, but I've heard good things about as well. Perfect. So, my general advice about A levels and time management. So, I am not the best with time management, especially at the moment, because I think just starting uni has been a bit, just being in a new environment and getting used to it, it's been a bit tough for me, but we're getting there. But in during A levels, I think I was a lot better at it, and I had set out exactly what I was going to do each day. So I made a little to-do list each day, and during peak exam season, this was really useful. My friends who are a bit better at time management say do the work as soon as you get it. And I think that's probably quite useful. And for A levels, I'd say what really helped me was doing every single past paper. So, especially for maths and chemistry, I completed all the past papers for Edexcel and I did the mock set papers. And then I started doing international A level papers and other exam boards. And this was amazing. Like, learning the questions repeat themselves so frequently and getting into that system of knowing what sort of questions are available really helped. So yeah, for maths and chemistry, I did all of them. For biology, not so much because I think I was a bit stronger with biology than I was for chemistry, so I focused more on that. And I'd say on top of that, it's really important to reflect on your past papers. So after I've done a past paper, I'd spend half an hour to an hour going through, analysing my mistakes, and I'd make Anki flashcards of my mistakes, especially for chemistry. I found that was really useful because of how repetitive it is, um, just to make Anki and those questions and the mark schemes repeat itself again. So I would make flashcards on common mistakes that I was making, and then review those flashcards daily. Um, I'd say as hard as it is you should really enjoy sixth form. Looking back, I think sixth form was one of, yeah, it was a great point in my life. As hard as it was, I made some good friends. Although initially, I think it's really important to be aware of who you surround yourself with. Um, Initially, I wasn't. I don't think I was around people who were probably the most, who didn't align with what I wanted to do the best. But as I found those people who were wanting to work hard but also have a good time, I think my work-life balance was a lot better. And having medic friends personally really helped. So all of my friends wanted to do medicine or dentistry, and going through that process together, complaining when it was hard together, and celebrating our successes together was such an amazing process. And for interviews and UCAT and personal statement, my friends really helped me go through my personal statement. We would edit each other's, give each other advice. UCAT, we'd work together on problems that we didn't understand. And for interview season, we'd interview each other during our free period. So we'd just test each other on flashcards and give ourselves feedback. And I think that was such a big factor in having had my offers and getting those interviews. Just having had my friends and that support system around me was really, really useful. And I think linking into that is, I'd say it's really important to have good relationships with your teachers and your head of year. So with your teachers, I found it was really useful, and I definitely annoyed my chemistry teachers, but just I would always go up and ask with come with past paper questions that I didn't understand. So when it got to topics that I didn't understand, I'd be like, can you explain this to me? I don't fully understand this. Can you go through this with me? And it was really useful to get that help from someone who does know what they're doing. So I'd really utilize your teachers and build those relationships early on so you can ask them for support later. And your head of year, because at least at our sixth form, they're managing your application, and it was a bit difficult for some people. But I know I know they shouldn't, but people definitely will have their own subconscious biases. And if they like you, they're probably more likely to give you the predictors that you want. So yeah, I'd say building that relationship, and they'll be able to support you through our applications. So our head of year, she helped me with my interview prep and for other subjects and other uni. So it was really useful. And they'll be aware of when you have to miss days for interviews, etc. Yeah, I mentioned, oh, oops, let's go back. I think I mentioned to-do lists and blocking out time. But I think, yeah, that especially during exam season, it helped for me to have a set list of things to do and specifying times. And because I was doing so many past papers, and I'd go to the library in the morning, do set a 2 hour block to do my past paper, mark my past paper, and then I'd have a little bit of a break, do some flashcards, and then I'd do my second past paper. And just I liked having past papers to block out my time. That really helped. Keep up to date from the start is a big thing. So I I revised for each topic test, and I think that helped me. I tried to consolidate my knowledge for every single topic test and generate resources. And eventually, when you get to the end, that buildup of resources is so useful. So you're not scrambling to make those flashcards, not wasting time. You can focus fully on applying your knowledge. Um, I really do think that if you work hard enough, you will see your results. And I know this doesn't necessarily um this doesn't necessarily apply to everyone, but I feel like if you do put in the work, eventually, even if it isn't straight away, if you continue putting in the work, the results will show. And I just would think that it's really important to keep going, even if you don't do great. I remember when I was doing four A levels, I got a B in my chemistry mock in the end of year 12. And that was really, really annoying for me, considering that I needed an A star and I knew I needed an A star. So I kept working on chemistry. Chemistry was the bane of my existence for the last 2 years, but kept working, and eventually it worked out well. And I actually got third highest in my year, which I was quite proud of. Um, find methods that work for you. Linking into the topic point before, some people um, I think they're working hard, but they're working and spending time on methods that aren't efficient. So if you're just copying out notes, is it you just need to make sure that you're using different methods that work for you. And I find for me, mind maps are really, really useful. Just to consolidate and visualize my knowledge. I'm a really visual learner, so to see how everything is linking on paper was really, really useful. And I did mind maps for all my topics, sort of in biology especially. And just general advice for the med school application is I'd say don't stress too much about the UCAT if you do badly. You can always apply strategically, and if you're not feeling confident enough with your UCAT, feel free to move the dates, but don't keep pushing it back to the point where it gets to September. I think September is quite a difficult time to do a UCAT plus statement and UCAS. So I was really glad that I did it end of August, and I spent all summer just preparing for it and focusing solely on my UCAT. But if you don't do too well, just know you can apply strategically and you will still most likely have options. I don't know, I don't remember what his called, the guy is called, but he has there's a big PDF file of all the universities and their UCAT cutoffs and where you should apply and ranking them based on where you should apply and what they prioritize. So definitely have a look at that. I'll see if I can find it and I'll send it to Serena so she can pass it on. Um, Again, if you're not doing four A levels, I think, or an essay competition, I think it's really useful to do EPQ. I didn't do an EPQ, I did some essay competitions instead, but I think you need one or the other just to show that you can have that those to build those research skills, those essay writing skills, and especially if you're coming here, if you're planning on coming here, there's a lot of essay writing. So to get into that concept of essay writing and just thinking academically, and using research is quite a good skill, I'd say. One very key thing is a lot of universities will ask you to demonstrate leadership and teamwork skills. So for every single one of my university interviews, apart from Cambridge, I was asked about leadership and teamwork in one aspect. So especially if you're early on in year 12, I'd say find activities that demonstrate those leadership and teamwork skills. So maybe start a society or um, organize events, and that will help you apply your skills and reflect on that those processes during interview, I'd say. And again, if one part of your application doesn't work out, you definitely have to keep going. If you give up and you decide, oh, I don't want to go to med school, I've not got any offers, I can't get into med school, what's the point? I'm not going to focus on my A levels. You're so restricted because if you get CCC or BBC, you're not going to be able to get into graduate entry medicine because they look at your A levels. You're not going to be able to apply again if you're doing a gap year. So the options are always there. So I definitely say if you don't end up getting any offers, just focus solely on your A levels and ensure that you get the best possible grades that you can. And that just opens the horizons for you more for everything else that you want to do. Even if it's not medicine, just applying for other courses as after a gap year, having the best A levels is going to give you the best opportunity to get in. Work experience or volunteering in healthcare, I'd say, is extremely important. My work experience was what consolidated my decision to study medicine, and seeing that firsthand was honestly amazing. I was in a general surgery ward for HPB, and it was just awesome seeing general surgery. Um, and I think I just decided that I want to be in an environment like this. I like being around these people. So I'd say that that experience was very useful. Volunteering in healthcare is what my other friends have said. One thing that I think I've realised now that I'm here is that the skills that you demonstrate in your interview really do apply to your med school application or med school experience. It's definitely been a lot harder than I thought it would be. But those time management skills that they're asking you about, those leadership skills that they're asking you about, really do apply because you've got to manage your time to stay on top of your work. And I know regardless of what medical school you're at, it's going to be hard. So you need to be able to have that support system, that those coping mechanisms for when it gets hard. So I wouldn't just bluff it for an interview because you're going to get here and you're going to realize that it really is a lot harder than you thought it would be. So yeah, I'd say that it's really important to be aware of that when you're coming in and when you're applying, and maybe don't lie to yourself or lie to the interviewer just to get here and realize that it's a bit too hard and drop out. Um, as I said, every past papers, apply for anything and everything, especially if you're in year 12. I applied to lots and lots of summer schools, but I just got rejected. But it's still, I got into one of the many, so I applied for, but still, I'd say you never know if you're going to get in. And a lot of these summer schools give you guaranteed interviews or reduced offers or benefits like that. So Bristol definitely gives a guaranteed interview regardless of your UCAT score. So if you can start, maybe join the Bristol summer school, and I think Nottingham does so too. So definitely look out for these things and search up University of like Essex, or no, Southampton, Essex. They all do great summer schools and programs that will support your application. But on the same side, if you don't get in, it's not the end of the world. It really is what you make of it at the end of the day. And I think my final thing I'd say is how important reflection is, especially for your interviews. Um, all of my all of my interview prep was based on a reflection. And I think when you take the time to stop and think about what you've done, what skills you've gained from it, I really think that that helped me create interview answers that were genuine and that I felt like my answers were quite genuine on why I had these skills and why I wanted to do medicine. So just reflecting on what you've done, and it doesn't have to be in medicine necessarily. Like I reflected a lot on my role as a swimming teacher because of how much I had to communicate. I had to vary my communication to different students, to different abilities, speaking to parents, and just the whole. Yeah, it was a lot of skills that I found were very useful, and then I'd apply that to medicine and how that is important in a medical um, atmosphere. So yeah, and also just on the topic of essay competitions, I think I wrote it in my slide, but all the colleges here have their own essay competitions. So definitely just search up. I think there is also a massive PDF file that I've definitely seen. I think it's Project Good, and he's written out all of the colleges or different essay writing competitions available. So definitely check that out if you're interested in doing an essay writing competition. But yeah, that's generally my application. And if you have any questions, I'd be happy to answer.
Thank you so much, Anujin. That was super useful, and I'm sure all the other people here that attended also found it really helpful. Thank you for coming on. I know you have a
Of
really
course,
busy schedule now,
of course.
because you did talk about how hard it is to manage stuff, but